We know in the thick ascending limb of loop of Henle there are NKCC2, that is sodium potassium 2 chloride channels. The sodium, potassium, and 2 chloride ions are taken in via this channel. There is a Rome K, that is renal outer medullary potassium channels, via which potassium is being excreted out along with H plus. And on this side, on the basolateral side, we have the 3Na plus 2K plus channel. Now, in other than that, in the thick ascending limb of loop of Henle, there will be passive diffusion of calcium and magnesium ions via a protein known as claudin protein. This all will happen, that is good. But in Bartter syndrome, there is what we say defect in the sodium sodium potassium 2 chloride channel. Now, if there is defect in this sodium potassium 2 chloride channel, what will happen? Then there will be severe salt and water wasting, because we know via this channel sodium, potassium, and 2 chloride, all this salt and water are reabsorbed. So, when there is defect, there will be severe salt and water wasting, polyuria, and there will be failure to thrive. This will lead to secondary RAS activation. This secondary RAS activation cause potassium and H plus loss in urine, and thus there will be hypokalemia, and in the body there will be alkalosis because H plus is being lost, and along with that there will also be blockage of the passive transport, that was the calcium and the magnesium ions. So blocked passive transport of calcium and magnesium ions will lead to hypercalciuria, which predisposes to stone formation. But this hypermagnesiuria will not lead to very significant hypomagnesemia, because there is a magnesium absorption protein present in the intestine. So the intestine absorbs magnesium from the diet. So there is not very significant hypomagnesemia, only 20% magnesium is lost, we can say, via this magnesium. That's all about Bartter syndrome. Another thing is that we have the types of Bartter syndrome. There are five types, among which the most common is, or we can say, the classical type is the type 3, because type 3 is seen in adults, and all others, in all other cases, there we can see it is in the children. So then they fail to thrive. So type 3 is the classical Bartter, classical type. Now we come to the Gitelmann syndrome. So we know in the distal convoluted tubule there is a sodium sodium chloride symporter. So Gitelmann syndrome is the defect in this sodium chloride symport symporter, and in Gitelmann syndrome there will be less salt and water wasting, because that sodium potassium 2 chloride channel is a very more potent and significant channel for sodium and chloride and potassium absorption, whereas this sodium chloride importer is less significant, so there will be less water and salt wasting, salt and water wasting. So this less salt and water wasting will lead to mild hypokalemia and mild alkalosis, you can say, and polyuria. And one change here is the hypomagnesemia. This Gitelmann syndrome is associated with TRPM6, that is TRPM6. It is a protein involved in regulating the magnesium levels in the body. This defect is also associated with the Gitelmann syndrome. So this will impair the magnesium absorption in the body. So magnesium absorption is poor. So this defect, magnesium absorption is poor, and this will lead to hypomagnesemia in all the cases of Gitelmann syndrome. 100%. There it was 20%. Here we have 100%. So now in the summary, we can differentiate between Bartter and Gitelman. First of all, if we see the salt and water wasting, this is much more in Bartter than Gitelman. Tetany. Tetany is due to hypomagnesemia, which is less in Bartter than in Gitelman. If we talk about the urine calcium levels, then it is more in Bartter syndrome, less in case of Gitelman.